Welcome back to Those Millennial Pediatricians. I'm Dr. Aniksha,
I'm Dr. Zaishna.
and this is the podcast where we give you evidence-based, science-backed information to all things related to children's health topics. So today is super exciting because this is our first guest episode, which is really fantastic. So, bear with mostly me and Deshna. I feel like Jess will do fantastic in this episode. But we're super excited to introduce Jessica McKee, our guest for today's episode, and an amazing lactation consultant. So Jess has worked as a nurse in the NICU for over a decade, bless her soul, doing amazing work caring for families and infants. And as Daisha and I both know, the NICU can be a really stressful place for families. Parents can be there for a long, long time, so the work that the nurses there do is amazing. But she became an international board-certified lactation consultant in 2020, which we'll talk a little bit about what the IBCLC really means. And she started Good Baby Lactation in 2023. Since then, she's been supporting parents in reaching their breastfeeding goals, whether it's in person, virtually, or even prenatally. So thanks so much for joining us today, Jess.
Thanks for having me. I can't believe I'm the first guest.
Yeah,
Yes,
it's really
you
special.
are. And I didn't tell you this, Jess, but just so everyone knows, like I found Jess, I was on Instagram, and then I had one of her lactation videos pop up, and I loved all of her videos, and I was like, texting Anisha, I was like, I'm gonna ask her, I'm gonna DM her
Oh my
and
gosh.
see. And I was like, there's definitely a chance she's not gonna respond, and then she did, and I'm so excited. So
Oh yeah, I
thank
was
you, Jess.
literally scrolling through your Monday Q&A like yesterday, and I was like, "Oh, these are all really great points. I can't wait to talk about these."
Oh,
Yes.
there's so many things. It's like the more you start learning about it, the more that you're like, oh my gosh, there's so much I don't know, and there's so much more to know. So it kind of sends you down a rabbit hole.
Yeah, I'm sure. And as physicians too, we also have so many questions, so I can only imagine what a new parent would be going through in terms of reaching their breastfeeding goals. But do you
Yeah,
want to
it's
talk
a
about,
lot.
yeah, it's a lot. Do you want to talk a little bit about what made you want to start Good Baby Lactation?
Yeah, I think first being a NICU nurse because I was a NICU nurse before I was a mom. So I just became interested in it. The hospital that I work at has a lot of surgical babies and not really a lot of just grower feeders learning to breastfeed type patients at all. A lot of our babies aren't even eating at all. So there isn't a lot of breastfeeding in my NICU, but a lot of pumping, a lot of breast milk in general. So that's how I first became interested. And then when I was pregnant, I was also taking another like a lower level lactation certification class because I was like, I'll take this because then it will help me learn some stuff and then I can use it for work and for my personal life. And then yeah, I just kind of just started learning more and more about it. And I have 3 kids, so I've done it 3 times now. Um, so yeah, it's really fun. I really enjoy it. It's kind of a fun part of my job. So I work in the hospital and then I also do home visits. That's like my side job. So it's great. I love it.
That's awesome. Lactation is such a cool topic. Every time I talk about it or we talk about it in clinic, it's just the reflecting on the fact that our bodies can do that and that we can provide and exactly how all the hormones work and everything is just really
It's so weird. Like one of my coworkers was asking me, like randomly people just come up to me and like, can I ask you a question? And then I know for sure it's going to be something about lactation. I'm the only nurse on my unit that's also an IBCLC. Like we have a lactation department, but I'm the only nurse that's a IBCLC. So whenever there's a lactation question, someone asks me. So whenever somebody says a cryptic, like, can I ask you something? If I know they have a baby, I know they're probably asking something for themselves. And
You
then
already
if
know.
not, if not, I just like assume it's about lactation. So she's like, "Can I ask you something?" And then I said, "Yeah." She's like, "Okay, this is so weird." And she went on to ask me a breastfeeding question. And she's like, "But that's what your body really does?" And I said, "Yes, it's so strange." And she's like, "I love that you're a lactation consultant and you have 3 kids and you're still like, this is crazy." It's so weird. It's so complex. It's just a really interesting organ system that I didn't really learn anything about in nursing school. I don't think you learn much about in medical school. It's kind of
Nope.
an overlooked organ system for some reason. I think we forget that the breasts are an organ. So yeah, it's just really interesting.
You must be so high in demand at your NICU and just in your general circle. So that's
Yeah, it's kind of
amazing.
one of those things that you think like, oh, I prepare a lot for labor and delivery, but like this it won't be that hard. The baby will just come out and they'll know how to eat and it'll be fine. And people spend, I find, much less time preparing for breastfeeding, even though they're going to spend way more hours than they did in labor breastfeeding. So, yeah, it's a very, I think when you realize, oh my gosh, I need help, you're very desperate and very frantic. So it's good to set up that help ahead of time if you can.
Definitely. And going off of that, we've mentioned or you mentioned IBCLC. Do you just mind explaining that for parents who don't understand or are looking into a lactation consultant?
Oh, sure. So IBCLC, I wish it was like not
Long.
such a mouthful.
Right? Yeah.
I know. And consultant makes it sound like it's just kind of like a fun, like bonus, like I think people don't take the credential very seriously because it's like a weird name, but that's just a
Right.
side note. But it's International Board Certified Lactation Consultant. So the certification is a worldwide certification. It's not separate for different countries, different states. It's one certification for anywhere in the world. And then I find that a lot of it is you have to recertify every 5 years. And a lot of it is taking classes and doing CEs on things that are interesting to you or things that you see changing, like breast pumps and breast pump technology, and our thinking about how breast pumps should fit has changed a lot in the last 5 years. So I think to be a good lactation consultant, you need to always be taking classes and, going to conferences and signing up for webinars and whatnot on things that you're interested in and really trying to stay up with the times.
What is your personal favorite part of being a consultant, aside from, being a NICU nurse as well?
Well, personally, I like how I do it because I'm a nurse at the hospital and that's my one job. And I help with breastfeeding when I can, but that's a very stressful, high acuity job. Like I mentioned, lots of surgeries, lots of very complex cases, lots of patients that stay in my NICU for many, 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 many months. So I like going to people's houses because that's like a fun, just more uplifting, just gives me a little bit of extra, I don't know. It's just something a little bit less stressful, but it's still like a big help. So like those parents and the parents in the NICU both need so much help, even though their babies are in completely different situations. And in one case, they're very, very sick. And in one case, they're healthy and they're at home. But to that family, this is like very terrible and very bad if they're having lactation trouble. So I feel like I'm able to use both of my jobs, like to help the other one, because all my lactation experiences help me in the hospital when I'm able to do that. And it just gives me a really like a mood boost because I love just like snuggling a healthy newborn in their house is just like the best. And helping those parents feel more confident about caring for their babies. And then my job in the NICU really helps me to be able, I think, to communicate with parents really well and to really understand where parents are coming from and really like help them with their stress. And really just be a good listener and a good educator. I think I'm really good at teaching parents because I have so much experience doing that from my hospital job. So my favorite part of my lactation job is just being in people's houses and just like giving them the confidence to like, this is your baby. I'm going to show you what to do and you're going to be an expert in your baby. And with a lot of practice, you're going to be really good at this.
I mean, that's so key, right? Because especially even if you have a baby that's in the nursery, not even in the NICU, right? And you've gone through this 3 times, Daisha and I have not personally been through this yet, but the idea of you just gave birth, you're trying to have that initial latch, you're working with a lactation consultant in-house, but you're so tired and you can't think straight. Then you go home, you have your chair or your pillow, you finally figure out your setup, and then you have to come to the pediatrician for your first 15-minute visit. And then you're trying to figure out how to get a good latch on, and the pediatrician's like, okay, well, let's see. And you're sitting in this little crampy chair without your pillow or anything, and everything's just not how you do it at home. And we're trying to help you, and it's always so hard from our end because we only have so much time, or we don't even have like a pillow or anything to really try to get a sense of what you're actually doing at home. So I feel like that in-person home visit is so great, and I'm sure it's so relaxing for those parents too, where they can like, okay, I'm at my own house, I don't have to dress up, take all of this diaper bag, the car seat, all this stuff, and we can just focus on getting a good latch and like properly breastfeeding, which I think is
I remember
so great.
so vividly taking my baby, my first one, because she had hyperbilia. I had to take her the next day I was like, please, I'll watch her closely. I'm a NICU nurse. Like, I'll come tomorrow. I'll poke her heel myself. Please just let me go home. And getting out it's like, oh my gosh, this takes so long to get out the door for just like one small human. And you're like, oh wow, this is my life now. Like, this is crazy. And like, you just had a baby like a day or two ago. It's wild. And mom brain is a real thing. Like physiologically, like your brain actually changes. So when people are like, I just feel like my brain is not working properly. It's like, that's because it's not, because like you just went through a really big change. So yeah, I can tell the minute they open the door, like what the vibe, like my hospital experience really helps me do. Like the minute I meet them, I can tell like, okay, what's their anxiety level like? How much support do they have? Sometimes they just start spilling their whole birth story to me. So it's kind of like a mental health, like I'm not a certified mental health specialist in anything, but it's a lot of like therapeutic listening and a lot of talking and a lot of like validating feelings. Because yeah, it's a really hard time.
So, Jess, we're gonna just get into the first segment, which is kind of laying the foundation out. So, do you mind just explaining a little bit about what lactation actually is and how it kind of works in our body?
So lactation is our ability to make milk, which all mammals have. And there's different types of mammals, which is just kind of related to lactation, and we're the carrying type of mammal, so that's why our babies want to be on us all the time, and our milk is such to feed frequently. So other kind of mammals that leave their babies and then they go and hunt and whatever, and then they come back later for their baby, their milk is a little bit different than ours. So our milk content of the protein and the fat and all of that is such that our baby should be feeding really frequently, which is a surprise to most people. Like they really want to get their baby on a schedule, and like that's not biologically realistic. And babies aren't robots, so they're probably not going to do exactly what we want them to do. So that's just good to know, like normal for your baby to be held all the time, normal for your baby to be fed really frequently. The breast development in puberty is really important. And sometimes we find people struggling with low milk supply later on. They had some endocrine disruption during that time and didn't build enough milk-making tissue. The breasts are the only organ in the body that they kind of come to life when we're pregnant. So what's something I ask when I'm doing consults, like what breast changes did you notice in pregnancy? Because you should notice your breast changes in pregnancy. If somebody says they haven't really changed, they haven't gotten any bigger, that's a big red flag to me that I don't know if they have enough milk-making tissue in there. Milk supply isn't dependent on breast size, but there are certain characteristics of breasts that we can look at to see, is this person going to have a capacity for a full milk supply? So puberty is a really important time where we build those building blocks. Then when we're pregnant, they kind of come to life and you start making colostrum in the second trimester, like around week 14 to 16. Which is why when people say like, has your milk come in yet? It's like, it's already in there. It's in there. It just needs to change to the mature kind. You've had it since the second trimester, which is good to know because people are kind of like waiting, like, where's the milk? But you start making it in the second trimester. And then when the baby's born and all the hormones change and the placenta detaches, that's our signal to start like the milk making process. And then when we wean, all those cells go through apoptosis and die. And then if you get pregnant again, then they come back to life and there's actually more than the time before. So that's really key for people to know that may have struggled with a low milk supply. You have a higher capacity to make milk with every pregnancy because you kind of grow more each time, which is really weird, like we talked about. And really, it's a really fascinating process. I find we don't spend a lot of time paying attention to our breasts until we're breastfeeding. Like hopefully people are doing like self-exams monthly on themselves, but otherwise we're not really paying a lot of attention to them aside from like how they look. So it's really important when you're pregnant to kind of like get to know them a little bit because when the baby comes, you're going to be spending a lot of time touching them.
Do you quickly mind touching on like prolactin and oxytocin kind of, because I feel like that's referenced a lot in terms of producing and then the milk kind of leaving the body?
Yes, the milk ejection reflex. So the prolactin levels, if you draw them when you're not breastfeeding compared to when you are breastfeeding, there's different baselines of what's normal. And that frequent stimulation at the breast is what builds the prolactin receptors in the breast that we want the prolactin to latch onto those receptors so then you can your body can kind of figure out how much milk you want to make. That's why early and frequent stimulation is really important by the baby or the pump. And then the oxytocin, this is the really cool one. When your nipple senses that something's on it, either the baby or the pump, you get a reflex up to your brain to tell your body, okay, release the milk. So there's these tiny little microscopic muscles surrounding the alveoli, like where the milk is made and stored, higher up in the breast. And then those little tiny muscles, your body senses, the nerves in your nipples sense that something's there. And then it sends a signal like, okay, release the milk now. And that's the letdown. And that's when the milk like comes from up in those sacs where it's stored and down and out the nipple. If you look in an anatomy drawing of the breast, kind of what it's drawn like isn't actually what it is. Dr. Katrina Mitchell, she's a breast surgeon in Santa Barbara. She has a really great website called Physician's Guide to Breastfeeding. And she has some really cool art on there kind of showing actually what the breast looks like inside. And really the milk ducts are very like tangled and innumerable. They're not like little roads going down like we see in the picture. But the milk has to travel from up higher and then all down through those squiggly little roads, the ducts, and out the nipple. Some people can feel that when that oxytocin travels from your nipple and up to your brain to tell your body to release the milk. Some people can feel that reflex and other people can't, and both are normal. It doesn't mean you like don't have milk if you don't feel it. Some people have a great milk supply and they don't feel it at all. But that's also that oxytocin response is tied into a good pump flange fit, which I'm sure we'll talk about later. But yeah, oxytocin, same hormone like in orgasm, same hormone in labor and delivery. It's all the same one, which is why cuddling your baby before you feed your baby and getting those like feel good feelings helps with your milk supply because it helps you to relax and release the milk better.
Yeah, oxytocin is such a cool hormone for sure. And I think that's one of the big benefits of breastfeeding is that bonding that you get. And so I think this is a great segue into our next question because there's obviously a lot of benefits of breastfeeding for both breastfeeding moms and for babies. So can you touch a little bit more on all the different benefits for both of those parties?
Yeah, so for moms, it's interesting. The link to postpartum depression and breastfeeding, in one sense, people that breastfeed have a lower incidence of postpartum depression because of that oxytocin that they have flowing a lot. But if you're having breastfeeding trouble, that could really exacerbate your symptoms of postpartum depression. So it's kind of, I mean, I don't want to say 50-50 because I don't have the exact numbers off the top of my head, but it's just interesting how your breastfeeding experience can affect that. Lower incidence of some cancers, lower incidence of diabetes is what has been found as some benefits for the mom. And then benefits for the baby, the biggest one is the immune factors because breast milk is a living substance and whatever sickness is around, you're building immune factors against that sickness. Then there's also been studies for decrease in asthma, decrease in ear infections, lots of different things. For NICU babies, decrease of necrotizing enterocolitis, which is really dangerous for preemies. So benefits for everyone.
What are your, like, if you had to pick a handful of top tips for a successful first time breastfeeding experience for a parent, and when you're consulting with breastfeeding parents, what things do you look for to tailor the best approach? And like, what are your general top tips?
My general top tips are to know the anatomy and physiology, which we just talked about, and how the breasts are going to change in that first week. Because a lot of things are going to happen and you're like not even going to recognize your body, especially for somebody that has smaller breasts. You're going to be like, what is going on? So to know that you started making milk in the second trimester and to know how that change is going to happen. Because when the milk first comes in, I'm doing air quotes, there's a big engorgement phase. So to know how to manage that engorgement phase, which is gentle massage, ice, it's an anti-inflammatory approach. This is kind of like a weird one that you wouldn't think, but like sometimes limiting visitors. It depends on like the vibes of your visitors in your family. Because if you have someone that's going to stay in your house, no joke, I had a coworker that I was supposed to talk to her on the phone and she's like, sorry, I've had visitors here for 8 hours. Like, can we talk tomorrow? She needed help with breastfeeding. And I was like, why do you have someone at your house for 8 hours? Like, that's insane. Who wants to host somebody for that long when
Unless
when they
they're
just
like
had a
cleaning
baby.
and doing all the laundry and doing
Exactly.
everything, then
Exactly.
no.
So she's like, my cousin's been here for 8 hours. Can we talk tomorrow? And I was like, oh my gosh, please tell her to leave. Just because it's hard to be feeding your baby frequently and practicing all the things you need to practice when you have visitors there all the time. To focus on latch and positioning, which we can talk about more like specifics, but if it hurts, then something's wrong. So don't just like tough it out like, well, I know the baby needs to eat, so it's fine. And then your nipples are bleeding and you're like, oh, well, my friend says like eventually they'll stop bleeding. Like that is very abnormal and that should not be happening. So some amount of sensitivity, especially the first time, like can be normal, or if you had some damage on like the first or second day, that's just getting better over time. So maybe you latch the baby and then initially it hurts for like 10 seconds and then the rest of the feed is fine. That could be in the range of more normal. If it's like toe curling pain that you're dreading feeding the baby and it's very uncomfortable, that tells us that something is wrong. So those are like the three of the main things that I
So
talk about.
sensitivity is normal, pain is not. So that's a really important point to remember, that if there's ever pain, then you should probably look into why that's happening. Is that
Yeah.
a fair way to summarize that?
Yeah, I think it is, because if it's really hurting, also that's going back to the oxytocin, though that cortisol and all that stress that you're feeling because it's uncomfortable is going to really inhibit your letdown reflex, because those hormones are going to compete against each other. And then also the baby's not going to get as much milk as they need either, in a lot of instances, because you're not going to be releasing as much milk and they're going to get much more if they're latched on effectively. So even if you think like, I think everything's going fine, but I don't really know, and you have the opportunity to book a lactation appointment with someone, then I always suggest doing it just to make sure. Like we always weigh the baby. Well, I don't know, most people do, weigh the baby before and after the feeding, and we can kind of see how much they got, which they're not going to do that amount every time, but it just like gives us a good idea, and it's kind of cool to see. And just to have an opportunity to ask the questions that you want to ask that have come up. And then maybe just before you have the baby, kind of having an idea of what lactation consultants are in your area. So if you are encountering that, like, oh my gosh, why do I have all this nipple damage? Or why do I have all this engorgement that's not going away? Then you know who you're gonna call instead of trying to find someone at 2 a.m.
Definitely. And I feel like that stress and that pain is super important. And I think we try to stress this in our visits too, as if, especially if you have a mom who had a C-section and she's having a ton of pain afterward and she's like, no, it's okay. And you see her visibly uncomfortable, and then just saying, you should reach out to your OB about some pain medication or how this is going. Like, let's look at your incision. Let's make sure you're doing well, because forcing yourself through that or pushing through that doesn't do you any favors. It doesn't do baby any favors. And then it just ends for a really miserable time for everyone. Yeah. So I think
And that's a
super
great point, because a lot of times people are afraid, this probably segues into another question, are afraid to take a medication because they're breastfeeding, but there's so many medications that are safe to take. And 99.9% of the time, the pain prescription that your doctor gives you, like they know you just had a baby and it's your OB, and so they're used to doing this all the time, and they're going to give you something that's safe. But that's a big fear that I see a lot, especially in the hospital, where a lot of those moms have had C-sections or really, really difficult deliveries. Sometimes they're hesitant to take something, but it's really important to help make yourself comfortable for not only your recovery, but your breastfeeding experience too.
Can you address like positioning and latching, how to get a proper latch to avoid the pain that we just talked about and kind of maximize that milk output or transfer? What do you recommend?
I would love nothing more, because most of the time something needs to be tweaked, and it's just these like little tiny tweaks that can make such a big difference. Okay, so the first thing is, if you guys try to open your mouth really wide with your neck flexed, it's really difficult to do. So when a baby's like
Trying it now.
squunched,
Yeah, not us trying to.
I know. It's like we look really attractive when we do that. So if the baby is like squunched like that, they are not going to be able to latch on deeply. We really want them kind of in this kind of position. Like when we like take a drink of something and slightly tip our head back, that's the position that we want the baby in. So a really simple thing to do is, if you see like that you guys could do at work, or that you could tell a mom to do, if the baby is too far, like this is my left side, if I'm feeding the baby over here and they're too far this way so that their neck is squunched, slide them down this way because they need to look up to get the nipple more. So a lot of people will say like nose to nipple. I used to say that too, but then I heard someone else say the chin leads the latch. And that's almost a better visual, that the chin needs to be coming in contact with the breast first. Because then when the chin comes in contact with the breast first, then that triggers the mouth to open much more. And babies can use their feeding reflexes much better. That's another really interesting thing about lactation is we're working with the mom and whatever's going on with the mom and with the baby and whatever's going on with the baby. It's really two separate patients that work together. But having that chin in contact with the breast helps them to open their mouth more. So the chin should be touching and the nose should be free. And most parents will think like, oh, that's so the baby can breathe, but the baby will breathe just fine. If their nose is touching the breast, like their nose, it's kind of pushed out to the side and they can still breathe. If they really can't breathe, then they won't. But that's more to show us that their neck is in that optimal positioning, that their chin is touching and their nose is free. So sliding them towards the other side. Or if there's any sort of gap, there should be no gap between you and the baby at all. Like you should be tummy to tummy, that not even a piece of paper can fit in between you. So if there is a little gap and you notice your baby isn't kind of in that head tipped slightly back position, just tuck their butt in. And oftentimes tucking in their butt super close to you, if there's a gap between their butt and your body, will kind of, when you tuck it in, then that'll naturally put them in a more extended position and help them get that slight head tilt back. So tummy to tummy, chin leads the latch. Those are the main two. And then the third one is that a lot of people will use a breastfeeding pillow and kind of just set their baby on the pillow like a shelf. And we want to avoid doing that because babies really want to be in a face down position when they feed. That's how their feeding reflexes work the best. So if there's a gap between you, or if you find yourself, this is so easy to do, lean forward and kind of chasing the baby around with your boob. And before you know it, you're on the edge of the couch and like your baby's like falling away from you on the pillow. We really want to be leaning back so baby can be in a more face down position because their feeding reflexes will fire so much better. They want to feel like super secure. And if they feel like they're kind of on their back, kind of falling away, they're not falling because you're holding them, but they don't feel secure like that. They really want to be face down and they want as much of their body touching something as possible. So those are the main three.
I love that. So it's like if we had to summarize, it would be kind of chin to breast, nose can be kind of free, body to body like contact, so such that even a paper can't fit through, and then kind of tummy down ideally so that they're not completely on their back or falling away, quote unquote.
Yep. And that's really more comfortable for your neck and shoulders too. Like we spend so much time as moms like hunched forward. And we're like, oh, my neck hurts. Like, oh, because I'm like a hunchback all day because I'm holding the baby, feeding the baby. And when you can just like lean back, like the corner of your couch is a great place. Like get in the corner of the couch, have your feet up, or in your bed. Anything that you can lean back a little bit more is so much better for you and the baby for feeding.
Yeah, I think the idea of like bringing the baby to you, not bringing yourself to the baby, we see that a lot, especially in those visits, right? Again, those uncomfortable chairs, they're like hunched over, and it's like you already did so much work. You don't need to keep doing work and hurting your back. Like, let's lean back. And I think the other point too about there's two people involved here. There's baby and there's mom, and that might change with each baby too. You probably know this more than the two of us. And so what might have worked the first time might not work the second time and third time. And it's not a reflection of you as a mom and your ability to breastfeed. It's that there's another person involved in that, and they are just brand new to the world and they're still trying to figure it out too. So I think that's super key that you mentioned that. Do you want to talk about though, like what a good latch looks like? Because I think that's like a common question too.
So it never matters what it looks like. It matters how it feels. Yes, there are certain things on the outside that I can see like, ooh, this latch isn't going to be deep enough. A lot of people focus on like, oh, get the baby's lips in a fish lips. They need to have fish lips. But I could still, I'll show you right now, which doesn't help for a podcast, but I don't have to open my mouth very wide and I could still have my lips like this. Like fish lips means nothing to me. I care more about the angle of the corner of the mouth, that it's really, really wide and that lower lip isn't tucked in. If the upper lip is neutral, that's totally fine. It does not need to be a fish lip. So I like to tell people to stop messing with your baby's lips, because sometimes the baby will be latched on and it will be fine, but they think the lips need to be flanged more. So then they're touching it. And then actually by touching the lips and touching the breast tissue, they're actually pulling the more breast tissue out of the baby's mouth instead of helping the latch.
Worse. Yeah.
So neutral lips with a wide open mouth are totally fine. And then I always tell people to look at your nipple when it comes out of the baby's mouth. Is it creased? Does it have like a white line on it? Does it look like a lipstick? Those things tell me that it's not deep enough. If it comes out of the baby's mouth and it's basically the same shape or the exact same shape as when you started, then that's perfect. Because in an ideal latch, the nipple should be pulled all the way to the back of the baby's mouth to the soft palate. So it's soft back there. If you feel like a chomping feeling, that's when it hurts. That means the nipple is too far in the front of the mouth and they're biting it or using the hard palate too much. So then when you take the nipple out of the mouth, then you'll see that more pinchy kind of look or a crease on the nipple. And that will tell you that it's not deep enough. But a lot of people say like, oh, well, the lactation consultant at the hospital said it looked fine. I was like, but how does it feel? They're like, it really hurts. I'm like, well, then I don't care if it looks fine. I care how it feels, because how it feels is really going to tell us how the latch is. Like I saw a baby recently that was popping off the breast like constantly, could not maintain suction. And I thought, oh my gosh, that looks really uncomfortable. And the mom was like, it's fine. Like it doesn't hurt. So people's sensitivities are different. So some people might need like a really perfect latch for it to feel good. And other people like might not have as much pain when it isn't ideal. So that's really interesting too. So looking at it is a good place to start. And you can say, oh, you can kind of point out things like, I see this. Those things tell me that the latch might be good. Like how does it feel? And then get the feedback on how it feels.
The pain is obviously a really common challenge that a lot of moms face, whether it's first baby or not. And I think with that, something that we hand out a lot at the hospitals, we hand it a lot at the clinics, are the nipple shields. And I always feel like we hear different things about the nipple shield. So we'd love to hear from you, your take on nipple shields, and if that's something that helps with pain, if you offer that to parents or not.
They're such a polarizing topic. So some lactation consultants are like, you should never use one. And then other ones just like hand them out like candy and everyone gets one. We want to know why we're using it. So I think in some instances, a nipple shield is great. If that's the only way the baby will latch and you hate pumping and you just really want to breastfeed and you don't care and you're going to use a nipple shield and that's working for you, that's fine. In other instances, it's just a Band-Aid on a problem and we don't know, like, why do you need the nipple shield? What's going on with the baby's oral function that's requiring them to use a nipple shield? Why do you have so much nipple damage that you need like a cover on it? So the more important thing is that we know why we're using the nipple shield, not is a nipple shield good or bad. They can really help if you had previous nipple damage and you're working on a latch and it's more comfortable. They can help babies that are having oral function problems. They can help babies that are transitioning from mostly bottle feeding to breastfeeding because it's that plastic texture. So they're fine. I use them sometimes, and yeah, but we want to know why we have to use them.
Yeah, I think that makes a ton of sense. I think another challenge that we don't come across all the time, but sometimes, right? So you might come across this more than we really do, but if there are any contraindications to breastfeeding or any other difficulties with like anatomy and things like that. So for parents who have undergone any sort of breast surgeries or tissue removal or anything like that, how do you typically approach that?
So I always ask on my intake form, do you have a history of any kind of breast surgery? Just so I know. Sometimes if you've had a breast reduction, then we want to know, like, we would definitely want to know that just in case some of those nerves were affected, or a breast augmentation. Cause sometimes people say, oh, the doctor said it wouldn't affect it, but maybe they accidentally did affect the nerves, and the nerves are really important for that oxytocin response. That's why we need them. So breast reduction in case any of the milk making tissue has come out in addition to the nerves being damaged, and then breast augmentation, and just any other, did you have to have like a breast biopsy or anything like that? That's just good to know. But none of those things are contraindications for breastfeeding. You can still breastfeed just fine. It's just good to have realistic expectations. Like if you know your nerves were damaged or you know that some milk making tissue was taken out, then knowledge is power. So you're not setting yourself up for an unrealistic expectation. Most medical conditions, you can just breastfeed right through it. There's very few that breastfeeding is completely contraindicated. If you're on like a chemotherapy, then you wouldn't be able to, or you have HIV. With some moms with HIV can breastfeed. It depends on what their viral load is. There's really few things that you can't breastfeed with, which is good for all healthcare providers to know. And medications too. A lot of it is just pump and dump, but they didn't even look it up. Like, look it up first before you tell her to to dump it. It's like we're all just afraid, so we just say, just on the safe side, just dump it. But really, we might not have looked it up. So it's important to look it up. And then as far as like nipple shape, like there's a lot of emphasis on flat nipples. I even had a mom in a prenatal consult once, and she's like, well, my nipples are kind of flat. My previous experience wasn't good. And then she showed me, and I was like, these are not flat nipples. Like, who told you that? Like,
Who told you?
I don't know why they said that. Or I had a patient once that said, in the hospital, they said my breasts were too fleshy. And I was like, what does that mean? Aren't they supposed to be?
That sounds ideal.
I don't know what that means. Yeah. But she was like too afraid to feed her baby, and like that made her very not confident. And so she was just pumping because she thought something was wrong. And I was like, why did they say that to you? So even flat nipples and even inverted nipples, because the baby's breastfeeding, they should be taking like a big bite of the breast, not biting, but like a big mouthful of the breast. So sometimes they will have trouble if your nipples are more flat. A lot of flat nipples will evert more as the baby breastfeeds, or there's little tools that we can use, like little suction, like nipple everters, to help draw the nipple out to make it easier for baby to latch on. Even people with inverted nipples can breastfeed too, and oftentimes they will evert more as time goes on. It's all about being educated. And if there is something that's going to inhibit us from having a full milk supply, it's just good that we know that instead of trying to kill ourselves. So I'm just going to pump 20 times a day and maybe then I'll make more milk if it's a condition that's not going to help you make more. So it's all about like having the right information and not blaming yourself if there's something going on that's like causing you trouble. It's nobody's fault. It's all about knowing about it and adjusting our expectations, which might not be originally the way we wanted our breastfeeding journey to go, but sometimes we have to adjust, and that could be like a grieving process for some people. So sometimes they do end up exclusive pumping because of an issue with their breasts or an issue with the baby, and that's not originally what they wanted to do. So it's all about getting that good support.
When should a new mom expect kind of her milk to come in? I know we talked about how it's already coming in like even prenatally, but kind of touching on the first few days and then transitioning to more mature like breast milk, so colostrum versus mature milk. And then how would you recommend managing the early kind of breastfeeding days?
On the first day the baby's born, you're only going to make about an ounce total for the whole day. Like the average is 37 mLs. And then by day 5, the average is 500 mLs. So it really increases exponentially in that time. Usually around like day 3 to 4 is when we notice that big increase. And then sometimes it could be delayed, like I mentioned earlier, sometimes delayed with a C-section, sometimes delayed with gestational diabetes, sometimes delayed if it's your first baby. Those are 3 of the main ones that I see. And then when it increases, it's milk that's increasing, but it's also an inflammatory response. So there's a lot of blood flow to the area and a lot of lymph fluid there too. So that's important to just know how to manage that, which would be with gentle lymphatic massage. So like going upwards, which sounds opposite because you're trying to get the milk out, but this is for the other fluid, up into the armpits, up into the collarbone where all of our lymph nodes are, just with the pressure that we're petting a cat. Nothing with the breast should ever be aggressive. No electric toothbrushes, no hard massage, no digging your knuckles into your breast, ever, 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 because that's increasing inflammation in the breast. So usually the baby's stomach on day 1 is so small, and they're usually only holding about 5 to 10 mLs at a time. So that works out perfectly, of course, for how our milk is transitioning. And then we're checking the baby's weights in that time too. So, all of that, to have a low volume for the first couple of days is normal. And then around day 3 to 4 is hopefully when it will increase a lot more.
Yeah, and I feel like managing parent expectations, like they come in and they're like, my baby's only like I'm only producing like a little bit. Like I'm worried they're dehydrated. And you're like, that's normal because you don't want them to be ideally drinking so much because their stomach is like yay big.
Right. I know it's very unfortunate that the ready to feed formula bottles are 2 ounces because if your baby needs that,
Yes.
then you think, oh, they're supposed to drink this whole thing. And the hospitals are much better now at telling you kind of. I had a patient recently, they had like a little chart of like, oh, day one, they should have this much, day two, this much. So then you kind of know. But if you're just breastfeeding the baby, you kind of don't really know how much is coming out. And it's only when you're pumping, if you need or want to pump, then you're seeing, oh my gosh, but the volume is so small. But that's how it's supposed to be in the first couple of days. Very thick and very low volume.
Yeah, I love that our bodies produce exactly how much our baby needs as they're growing. I think that's so cool that we just know exactly how much we need, and then our babies are like, okay, I'm going to stimulate you this much, and I know that that's going to produce this much because tomorrow I'm going to need this much. I think that's so cool and so fantastic that our bodies naturally do that. And I think we need to do a better job on the physician end of just celebrating how little is produced because that's exactly how much is needed. And that liquid gold is just, it doesn't need to, we don't need to have more than what we're already producing.
Yeah, it's interesting in today's time with pumping now because there's more pumps now than there's ever been. And then, of course, in our country, we have to pump because we're going back to work and we don't get a full year off like other countries. But people think they need a bunch of milk stored and they don't. And your body adjusts to how much the baby wants because babies don't usually drink everything that's available in the breast at any one time. This is for a full milk supply, like everything's normal, not in low milk supply situations. Um, they're going to leave some milk behind. So your body will kind of just adjust to what the baby wants. And if you also put the pump on after you fed the baby, then your body thinks you have twins and people think they want an oversupply, but really that comes with another whole host of issues. And actually it's not great to have that. In the times before pumps existed, we would never know like, oh, I have the capacity to make so much more, or I'm not pumping enough because we're just putting the baby to the breast and then if everything's going fine, then everything's going fine. We didn't spend as much time like over analyzing the volume.
What are the tips that you provide to help boost milk supply? Besides, of course, I think we've talked a lot about like, stimulation and things like that.
Yeah, frequent feeding, or pumping, and really getting to the root cause of why is the supply low. Some people say like we really need to treat lactation as like a how well are things going in the body. There is a reason why your milk supply is low. It's not just, oh, I couldn't do it. Well, why? Did you have a thyroid problem? Did you not build enough milk making tissue in puberty? Do you have another endocrine disorder? Is your A1C too high? There's all these complex systems in the body that all work together. And there's a reason if you are stimulating your body enough and the pump fits well or your baby's latch is good and you're not making enough milk, there's a reason why. It's not because you didn't try hard enough. It's not because you're doing something wrong. It's that there's something going on medically. We just tend to not think of breastfeeding as a medical condition for some reason. So sometimes I'll have patients get their labs drawn so we can look and see what's going on. Like the thyroid is really tied to milk supply. So yeah, there's a reason why. There's certain foods and medications, galactagogues, that can be supportive of milk supply. But not everyone is the same and not everyone is recommended for all people. There's some contraindications. If you have certain conditions, you shouldn't take this sort of herb. And then like culturally, there's a lot of herbs that different cultures, like they always have their postpartum moms eating and drinking certain things. And there's evidence for some of those things. And some of them are just like hearsay. Some things are like, oh, drink the Starbucks pink drink. It's like, there's nothing special in the pink drink. You're probably just dehydrated. And so then you felt like you made more milk because you were more hydrated because you drank a pink drink. Body Armor, they do a lot of marketing to postpartum moms now, which is really disappointing because they make it seem like something's magical. Maybe they're just a little low on electrolytes, not because of that specific product. So yeah, getting a lactation consultant that can help explore the root cause and refer you to other providers as necessary. Like sometimes I'll tell people, I think you should go see an endocrinologist and get to the root cause of some of these issues, is really helpful. Not just like, oh, feed the baby more. That's where some of the advice on social media gets a little like
Dodgy.
problematic and upsetting, because it's like, well, no, you're just telling her, well, you just need to pump more. But now she's barely sleeping because she's pumping, and that is not why she has a low milk supply. So really getting to the root cause.
I think the supplement thing comes up a lot too. And since you touched on it, do you mind talking a little bit about like what supplements you've heard a lot about, which ones you do or have seen really effective data on? I know you said it depends on the
Yeah,
individual
it
cases.
depends. Moringa is one that a lot of people might respond well to. Um, there's a lot of fenugreek free supplements now, which are good because fenugreek can sometimes upset your stomach, and affect your blood sugar. So people with blood sugar issues, probably shouldn't take anything with fenugreek. Um, oh my gosh, there's so many. There's so many different ones. There's a lot of companies that make like different combinations of different herbs now. But yeah, working with someone to tell you, like, I think this one might be good for you, or I think this one you should stay away from, can be really helpful. Sometimes they can help like support. And if you have the means to, and you want to buy a supplement, if you've checked that it's safe for you, and lactation consultants can't prescribe anything because I'm not a doctor, but I can say, check with your doctor. And then sometimes the doctor will say, well, whatever lactation consultant said, I don't know.
Yeah, yeah, I'm like, I'm not. That
Which is why it's so funny, your consultants, because so many times, and I think we'll touch on this at the end of the episode, we're like, lactation consultant, that's like your primary lactation source. So we're
Yeah,
like, whatever
I know.
lactation thinks sounds great to us.
I know. I hate the name. But yeah, there's a lot of things. And then you really need to be eating like 500 extra calories a day. That's just like a main one to do. That's for your general postpartum recovery, but that will help you. You need more in lactation, more calories than you do when you're pregnant, which is wild. People will say, oh, you need to drink gallons of water. No, you don't. You just need to be hydrated. A lot of times we will make enough milk for our baby, but at our own expense, and our body will just be depleted so much because our body has used all of its resources. So a lot of these things are to help support our body, not for lactation directly. So yeah, that's something to keep in mind. There's a really good book that you guys would probably like, and it's like, I have it for myself as a provider, but it's written for a layperson, called Making More Milk. And it has a whole chapter on galactagogues and all these different, reasons for low milk supply and things that you would do next and who you would refer to and things like that. But it's written for parents, like to know, but it's very helpful to me as a provider too. And then there's a great lactation consultant, Melissa Cole, and she has a whole class on herbs, to kind of like, so people can learn about herbs more. There's just like, there's so much to know. Like you could do a whole deep dive on just herbs. Like you could do a whole deep dive on pumping. You could do a whole deep dive on bottles. Like there's all these different facets of lactation that, like, there's just so much to know. So that's why the continuing education is never ending. But yeah, that book is really good. Making More Milk.
I just bookmarked it, so I will order that on Amazon. Can you talk about transitioning back to work and breastfeeding and kind of like your spiel on all that?
So I really want to make a class about this, and I just haven't had time because this is such a big topic and it's so stressful. It is such a stressful time and it's so difficult, and we do not get enough leave in this country, and depending on where you work can really affect your back to work experience. So my experience going back to work, because I work in a hospital in a NICU, so I have pumping rooms there that are for the moms and we can use them too. And I work with a lot of moms. So if I was going back to an office with a bunch of 20-something-year-old guys, that probably might not be the most, I don't want to stereotype, but might not be as supportive of an environment as like the environment that I went back to work. But also my back to work environment is really stressful, and you can't really time your day of like, oh, I'm going to step away at exactly this time, because you don't know what's going on with your patient at that time. Teachers, they have a really hard time going back to work, and that's a lot of moms that are teachers, and they got to do recess duty. They have a meeting. They have a lot of barriers to their pumping experience as well. So the main things to do, and I have like a little, like a 1-page, like freebie thing that's available to people, is to know the laws in your state of like what the pumping laws are. That's really important. To get to know your pump before you have to use it. Because if you've been mostly breastfeeding and not really pumping, and you're going to choose that first day you go back to work to use your pump, that's going to go really badly for you. You really need to make sure you know how to use it and that the flanges fit well. The flanges that came in the box are probably not your size. It's very rare for me that somebody actually uses those sizes. I would say 90% probably of my patients use a smaller size. So if you're not sure about the size, ask a lactation consultant. Do like a trial run at the daycare if you can, or with whoever's watching your baby. Like, could you do like a 4-hour, like when I go to work, I'm gone for 14 hours. Not everyone's is like that, but leaving the baby for the first day for like 14 hours would be like a lot. So if it's possible to do like, oh, can you watch the baby for like 4 hours and just kind of see like how you feel? You might not be at work, but you're somewhere and you're pumping, feel how it feels to be away for like a chunk of time. If you could do like a little trial run, then that could be really helpful. And then bottle feeding. If you're going back to work and your baby's like 3-4 months old and they've never had a bottle before, again, that's probably not going to go well for you. Really, the sweet spot to introduce a bottle, if you know you're going to need to be away from your baby, is like 4 weeks. So that would be the time to introduce a bottle before that suck reflex goes away. And then the baby's like, what is this? I just want my mom, because bottle refusal on top of going back to work, that's already stressful enough. And then that just really brings it up because you're like, oh my gosh, the baby is not going to eat when I'm gone. So those are the main tips for going back, and to just have a lot of patience and grace with yourself, because it's just very difficult physically and emotionally. And so many other good resources. Another good one for that is the Mom Attorney. Daphne is her name, like Mama, but the last A is attorney. And she has she's part of a group called Chamber of Mothers, and they have she has all these resources for like how you get to know, like what are the laws in your state and what are your rights and all of that sort of thing.
Oh, well, yeah, we'll give her a shout
That's
out
awesome. We'll link those in the description
in the
too.
description. Okay. So let's say, we talked all about going back to work and breastfeeding and all that. Weaning and breastfeeding beyond infancy. So how do you balance this with, kind of around the point where they start solids? When is it okay to start weaning off breastfeeding? And can you talk about extended breastfeeding as well?
So the World Health Organization and AAP both recommend exclusive breastfeeding for 6 months and then up until 2 years or beyond for as long as both of you want to do it. In our culture, it's much more common to wean earlier. The majority of us start out breastfeeding, but a very small percentage actually make it to the exclusive breastfeeding at 6 months even, let alone 1 year or 2 years. And a lot of that is tied into going back to work. So if you're weaning before your baby is 1, then you have to know that you're going to have to supplement. So if you have a bunch of milk stored up, you can work through that, and then you would give formula in the meantime until your baby's a year old. If you breastfeed until your baby's a year old, then when they're a year old, it's kind of as much or as little as you want, which is almost harder for some people because they're like, but I don't know, but how much? And I'm like, whatever, as much or as little. But a lot of us, like, at least me, like rules and like more black and white, but it's like however much you want to breastfeed you can, and however little you want to breastfeed you can. Weaning a younger baby is easier in a way from like them emotionally, because they're just not as aware and maybe don't have as many like emotional ties to breastfeeding than weaning an older baby or a toddler. Probably every time I do a question box, which I try to do weekly, at least one person asked me about weaning. And I have a little weaning, like 3-day email free thing that people can sign up for. And it'll send you 3 separate emails about weaning, like how to do it and, things like that. Some people wean and it's because they didn't want to. So that's another emotionally challenging thing. Like maybe their breastfeeding experience isn't going how they thought it would. A lot of people view breastfeeding as a like all or nothing. And it's not. There's so many different possibilities. Like if you have a low milk supply and you do some breastfeeding and some formula feeding, like that's that's great. And that's an option. I think people think I need to fully breastfeed my baby or fully formula feed my baby. And that's not the case at all. There's all different combos that work for some families. So when some people go back to work, sometimes they do some combo feeding if they can't keep up with the amount of pumping that they need to do to maintain their milk supply. Some people, there's all different things that you could do, and what works differently for each family is very individual. And then if you're weaning an older baby, an important thing to know, I'll plug another expert on this, another podcast, is all the emotional ties to it. A lot of times what the toddler is looking for is the emotional connection. If you're only breastfeeding once or twice a day, they're not getting a lot of milk in that time at all. It's mostly an emotional thing for them, which we tend to like, people get all weird about breastfeeding once the baby's one, but we also should validate the emotional experience too. It's like, yeah, we know they're not getting a lot of nutrition, even though toddler milk that you make for a toddler is tailored to a toddler. Like it keeps tailoring to the baby as they go along. There's still tons of nutrients in it. But if it's just, oh, they do it once a day before bed, and you just all of a sudden expect them to be fine with you just cutting it off and stopping, we really need to take their emotional experience into account, and they're looking for that connection. So replacing that connection with other things like, I can rub your back, I can rock you, we can sing a song together, you can have a cup of milk like while I hold you, different things to fill in that gap of that connection that they might be missing out on. And the person I was talking about is Emma Pickett. She's a IBCLC, and she has a book on weaning, and she has a really great podcast called Makes Milk. And she has a bunch of really excellent episodes on weaning, specifically like older babies and toddlers a lot of people experience weaning anxiety and depression. That could be another thing you guys can look for in your practices. With my first one, I got really anxious, and I was like, why am I? Because I'm not really a person that tends to have anxiety. Like, why am I so anxious? And I was trying to think like, oh, what's changed in the last few weeks? Why do I feel like this? And I was like, is it because of breastfeeding? Like I'm not breastfeeding anymore. It was before I was a lactation consultant. So really like going slow, doing like one feed or one pumping session every like several days is really the best way to do it. Of course, there's reasons we might have to do it faster, like medical reasons sometimes, but yeah, in general, slow is the way to go. It's a big change. This whole process is a big change on our minds and our bodies.
Yeah. Slow is the way to go. Our new motto.
That's right.
I love it. Yeah. We do want to be mindful of your time since your toddler is going to be imminent.
She is imminently
coming back. But thank you so much for being here. Clearly, we thought we could do this in an hour, and we didn't. So.
That just proves like we're
okay.
like literally touching the tip of the iceberg. There's so much to talk about, but
there's so
yeah,
much.
We got a lot of good information.
Amazing information.
Thanks for having me.
Thank you. Really quickly before you sign off, can you tell listeners like where they can find you for those that are not watching on video, and if they want to have you as their IBCLC, what that process is, or how can they get in touch?
You can go to my website, goodbabylactation.com. My Instagram is Good Baby Lactation. So all babies are good babies. I always say that. Are they a good baby? What does that mean? Some babies just have some babies just have a harder time with feeding or with fussiness, and we just have to figure out why. So everywhere is Good Baby Lactation. And then I have a weaning freebie, I have a nipple ruler freebie, I have a back to work freebie. I hope to make a back to work class someday. I'll do that. But yeah, that's where they can find me. And I do in-person visits in Ventura County. I live in Moore Park. So like Moore Park, Thousand Oaks, Camarillo, Simi Valley. That's kind of my service area. And then telehealth appointments, no matter where you are.
Amazing. Such a great resource. Thank you so much, Jess, for coming.
Thank you guys.
Yeah.
We look forward to listening to you on your new podcast when you decide to start one.
Someday. This year. It's my goal for 2025.
Oh. Yeah.
Okay.
All right.
Thank you guys.
Thanks, Bye.
Bye. Have a good day.
Bye. You too. Bye.
Okay. So Jess had to go because
we talked too much.
We talked too much, and we said it would only take an hour, and it took way more than that. And she has children, which, understandable. So.
Yeah, we have all the time in the world because we are childless right now. So yeah, but she does not have that same luxury. So thank you, Jess, if you're watching. So let's just do some summarizing and takeaway thoughts because I feel like we could write a book on this podcast episode. Like that's how much great information there was for
Yeah.
everyone.
Honestly, she should. She should have a podcast. She should write a book.
A
I
book.
would read it
I
multiple
would,
times.
yeah, I would read it. And like all this information was, we were just talking about how it was like news for us too. And that's how like little I feel like lactation medicine is emphasized in like our curriculum. So I highly recommend, I'm going to recommend this to like even our colleagues to listen to because it's great for even our appointments with our newborn visits. It's great. Okay, so summary and takeaway thought. One, breastfeeding is not easy and should be considered quote unquote a medical issue to address, but that doesn't mean you should be miserable or experiencing pain. Remember that you can have sensitivity, definitely, but pain is usually abnormal, and that should be something you visit with your IBCLC.
Yeah. Ways to successfully breastfeed, if that is your priority, include proper positioning and latching. So that helps a lot with the pain that Daishna just mentioned. Frequent nursing, skin to skin contact, again, avoiding that gap that Jess mentioned, and working with a consultant if necessary to work around having any different breast anatomy or surgeries. And so, like we mentioned, there's very few true contraindications to breastfeeding. So if that's something that you really want to do, that's something you can do. I think something else we didn't quite mention is that it's never really too late to breastfeed. You just might have different issues surrounding getting your baby to latch and producing milk supply and things like that too.
Yeah, and to go off of that, supplements for breastfeeding depend on individual cases. So there isn't really one supplement that works for everyone. You should work with a physician or your IBCLC to determine what may work for you. I think this is also really important as a side note, but like use social media with caution because not everything may be evidence-based. There may be some kind of financial opportunity for people advertising like a certain supplement, but things that have definitively shown some data for it to be helpful include moringa, which is a natural plant, and then fenugreek as well. That may be helpful and maybe somewhat effective, but it depends on different people.
Yeah. The next thing is there are ways to be successful in going back to work and continuing breastfeeding. So, a big thing is advocating for yourself by knowing your workplace guidelines for pumping and that you have rights and are allowed to pump at work. And for bottle feeding, you can introduce or practice with the bottle prior to work a few weeks before going back to avoid any issues with feeding at daycare or with another caregiver.
And finally, you can certainly wean off breastfeeding whenever you like. Although understand the older they get, they are getting or they should be getting other sources of nutrition, and the amount of nutrition that breastfeeding provides as they get older is a little more limited just because they're breastfeeding less. And a lot of it has to do more with the emotional connection rather than the nutritional source. And remember that slow is the way to go when you're thinking about weaning off of breastfeeding. And with that, we'd like to thank you for listening to our very first guest episode. We'll likely, sorry, rewind. I don't know where I was going with that. Thanks for listening to our very first guest episode. We hope to have on a lot more guests because this is a learning experience, not only for you guys, but for us as well. And this was definitely a great first guest to have on for our episode.
Yeah, we'd love to thank Jess again if she ends up listening to this again, because that was just so valuable and wonderful. And she put up with our constant yapping. So she's a real one for that.
With that, we'll see you at our next episode.
Thanks. Bye.
Bye.
Deuces.
Deuces. Okay.